Hi, everyone, and welcome to Henry Schein's webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein, and it gives me great pleasure to turn it over to Dr. David Reznik, who's going to give us the latest update on COVID-19 and dentistry.
Thank you, Gary. As always, it's a pleasure to be with you and to share some of the latest information we have on this pandemic, which has caused so many changes in our daily lives and in our work lives. I hope that everybody is staying safe, and I hope this information proves helpful. We have some new things to talk about today. I'm going to sort of outline them for you. As always, I'd like to start off with a general overview of where we are in the United States regarding the state of COVID. And I think that we all know, at least right now, we're seeing a trend downward, which is very important, but that's how long this lasts, one only knows. The effectiveness of the different types of vaccines presently available, and we do have some very good data to share today on preventing hospitalizations and death, but also looking at the production of antibodies and also looking at what natural infection does as far as creation of antibodies and how long they last. If a person has been infected with COVID-19 or SARS-CoV-2, is it recommended to be vaccinated? This is a question that's still out there, and we have a little bit of data there to share as well. A very important component is vaccination and pregnancy, and that's going to be a very serious part of our discussion today. And then looking at the booster review, that's the latest information that's out there, when we can get boosted, what we should get boosted with. So with that being said, let's get started on today's presentation. There have been almost 45 million cases of COVID in the United States. That is an extraordinary number of people, and we've now hit over 725,000 deaths due to this disease. So this is some of the latest data. It comes from the CDC, where we are tracking this information. Southern states, which have been some serious hotspots. My hospital really has been going through it once again. Thank God we're starting to see a decrease in our COVID-19 cases, but then some areas that are experiencing cold weather, mostly in the North and the Midwest, and some other states throughout the country are seeing an uptick. So it's not time to let your guard down. That's one of the things I think is really important. When we saw a little downward spiral of the cases last year, people got a little bit relaxed, and we saw an uptick in the new cases. New cases in Georgia and Florida are down 37% and 25% respectively compared to the week before. And we had some of the 10 lowest case rates in the past week, and that is continuing. However, a handful of states where the cold weather is starting to hit are seeing an increase. Actually, right now, about 15 states are seeing an increase. I wanted to go over some of the hospital data just to show you a little bit about the patterns that we're seeing. So if you look back in April, and what I'd like you to look is at the yellow line. These would be the net number of patients that we would have in the hospital with a COVID diagnosis. So you can see beginning in April 1st of 2020, that the cases were below 50, but then it started to go up, and you saw a little downward spiral when the weather started getting warmer. And then you saw this sort of interesting July, August uptick where the cases started to rise. And then, like we're seeing now, the cases started to go down at the end of September and through October. Now, if you look at where we were in 21, we had that huge winter spike, January and February, and then the cases started going down all the way down to the July 4th holiday. And things really looked good at that point. And then we had another one of those August, September jumps up. Now, again, we're heading down. So how does this compare to the rest of the country is sort of interesting and something I really like to talk about. Because as you see, there is a little bit of a pattern. The weather gets warmer, cases get better, people are outside. Weather gets cold, cases go up. Then over a period of time, as it starts to warm up, the cases go down. And now we have an extra value. We have people that are vaccinated. So hopefully it'll stay down this time. That is the goal. Over the last week, the 7-day COVID-19 average cases rose about 15 states or flat in 4 states. And the great news is that they're dropping in 31 states. And this is from the Johns Hopkins Coronavirus Resource Center that I just pulled. Cases are trending down in the right direction in the US overall. The daily average is down 10% over the last week. Again, this is great news. It's Halloween, it's family time, it's also the beginning of fall. And so really, even the death numbers are going down, and that tends to track a little bit further. So we have positive news. And as you know from watching these webinars, if there's something positive to find out during this pandemic, I'd really like to point it out for everyone. So let's look at the daily number of cases. And this again goes back looking at a different chart from the United States. So you can see that we had July, the numbers were really sort of low of 20. Then it sort of went down and we had this big winter peak. When we got to around July 4th of 2021, the cases were almost at our nadir, at our lowest level. Then we saw this summer spike, and now we're seeing it go back down. So it's very similar to what we're seeing in my hospital from what we're seeing nationwide. So again, the news is good, but I really want to stress the importance of maintaining precautions and maintaining all of the wonderful things we've done in our dental field, all of the HEPA filtration, the N95s, the face masks, all the wonderful work that we are doing to protect ourselves, our staff, and our patients. So what about the effectiveness of these vaccines in preventing hospitalization in adults? What do we know about this? Well, we do know that 2 doses of the mRNA vaccine, so that's either the Pfizer-BioNTech vaccine or Moderna, and a 1-dose viral vector vaccine, that's the Janssen vaccine or the J&J vaccine, are currently used in our country. Amongst adults in the United States without immunocompromising conditions, vaccine effectiveness against COVID-19 hospitalization during a period of March through August was higher for the Moderna vaccine, 93%, when compared to the Pfizer vaccine, slightly lower at 88%, and the Janssen vaccine or the J&J vaccine, which was down to 71%. So the implications for public health, although these real-world data suggest some variations in the level of protection by vaccine, all FDA-approved or authorized COVID-19 vaccines provide substantial protection against hospitalization, and death. If you look at a case-controlled study from the CDC, they actually looked at the effectiveness of 3 COVID-19 vaccines currently authorized. So this is actually the trial. They had 3,689 individuals from 18 states that required hospitalization. The analysis demonstrated that the vaccine effectiveness against COVID-19 hospitalization was higher for the Moderna vaccine than for Pfizer, which was significant, a P of P01. The vaccine effectiveness of both mRNA vaccines were higher than the J&J or Janssen vaccine, but all were highly effective in keeping people out of the hospital. The first of the 2-part study actually looked at the vaccine effectiveness in patients who were hospitalized. The second part of the study looked at antibody levels, and this is really where I think some of the data is also remarkably interesting. So if you look at question 1, vaccine effectiveness, as I've talked about, we had these 3,700 adults fully vaccinated greater than 2 weeks after. They looked at the vaccine effectiveness rate. And as I've discussed earlier, Moderna was leading the effectiveness at 93%. Pfizer was right behind at 88%. And a little bit further down is the Janssen vaccine. When they looked at greater than 120 days after the vaccine, so 6 months, Moderna was holding pretty good at 92%. Pfizer had dropped down to 77%, and Janssen was at 68%. And I think the Pfizer data we saw in the real world were studies that were coming out of Israel, where Israel started to use boosters before many other countries did because they were seeing this decrease in effectiveness. So Moderna does appear to have slightly better protection and better durability compared with the other vaccines. And why is that? And these are, the technology has been around for quite some time, but the vaccines are, relatively new. So what is the reason that we're seeing these better protection from Moderna as compared to what we're seeing in Pfizer and J&J. So the second question is, could the real world protection differences be due to the production of more antibodies? And one codicil to this study, one little note to the study is they didn't measure antibody levels in hospitalized patients, but rather antibody levels in healthy subjects. So there were 100 healthy volunteers who were immunized. Blood samples were drawn between 2 and 6 weeks, and they were fully vaccinated. 2 antibodies were measured. The anti-receptor binding domain antibodies and anti-spike antibodies. So there's the receptor and the anti-spike. And let's see what we find. The results explain what we clinically saw in the first part of the study. Moderna actually produced significantly more antibodies. And if you look at the anti-receptor binding domain antibodies, Moderna was at 4,200, almost 4,300. Pfizer BioNTech was closer to 3,000. And the J&J vaccine only was at a 51 number. If you look at the anti-spike IgG levels, Moderna was at 3,059, Pfizer was at 2,444, and Janssen was at 56. So the more antibodies that were produced had better protection and better durability, even though Pfizer had fewer antibodies and slightly lower protection and did not last as long. So that's why when we come up to our booster conversation, we'll see that the booster recommendations for Pfizer and Moderna are very similar. However, the booster recommendations for Janssen are going to be for everybody who is over 18. So we really want to increase the protection that we have for those that got the viral vector vaccine. So this is actual real life data showing why these are working. And I think that's important. A lot of times we're hearing, well, this one's better than that one, and this one's better than the other. But what is the logic behind it? What is the science behind it? Not just opinion, but what is the actual science? The real surprise from the study was the low levels of antibodies that were produced by the single dose of J&J's vaccine, which were in the 50s, whereas I previously highlighted the mRNA vaccines were somewhere between the 2,000 and 4,000 range. The lower antibody levels would explain the lower protection of J&J or Janssen vaccine that was seen in the first part of the study. So now we actually have real data looking at real outcomes and what we should do with that data. One of the most controversial questions that come up, and there's actually reason for the controversy, and I try not to really put much opinion in this. We're just going to go on what the data is showing right now. If you've had COVID-19, do you need the vaccine? Many people who have recovered from COVID-19 may emerge relatively unscathed from a second encounter, might even know they've had it. However, the strength and durability of many people who have recovered from COVID-19 may emerge relatively unscathed from a second bout of the disease. However, the strength and durability of immunity depends on multiple factors, including age, older means less protection, health status, we've already known how important that is, and the severity of the initial infection. That's the thing with natural infection. You can be on the very low end or that very high end, depending on what kind of disease you have. And the issue that we have with this is we don't really know per person how many antibodies do you have when you're infected. So if you have mild disease and you're young, how many antibodies will be there? I don't know that we have that data yet, but there's still more data. If you look at some of the recently published information from Dr. Iwasaki's team in May, it showed a stepwise increase in the level of antibodies with rising severity of infection. So for those who get really sick, there's more antibodies. For those who have a mild disease course, maybe don't feel good, maybe just never have symptoms. Remember, 50% of the people who show up into our office have either asymptomatic or pre-symptomatic infection. They might have a lower level. About 43% of recovered people had no detectable neutralizing antibodies, the kind needed to prevent reinfection, according to a study. The antibodies dropped to undetectable levels after 2 months in about 30% of people who recovered. So this information really stresses the importance that if you've had COVID-19, you really should get vaccinated because we don't know how long your antibodies are going to be there, how many antibodies you have produced, and whether they're going to be effective. However, there's more to the story. There are two consistent patterns that have emerged. 2 doses of the mRNA vaccine produce more antibodies and more reliability on that. And so an infection with the coronavirus disease. So basically, you get more antibodies and more durability with the vaccine. On the other hand, the antibodies from prior infection, they're more diverse. They're capable of fending off a wider range of variants than those produced by vaccines. So 2 points, and I'm going to try to re-emphasize this. You get more antibodies, more reliability than infection when you have both doses of mRNA or your 3rd dose if you're qualified to be boosted. However, the antibodies from a previous infection are more diverse. They're capable of fending off a wider range of variants than those produced by vaccines, which leads to this conclusion. If you have had the infection and then you've been vaccinated, you basically have superpowers. And as a big fan of Marvel and the DC world, I want to be as protected as possible. I don't want family members to get this disease from me. I don't want little kids and get this disease from me. I don't want grandparents or some of my peers who are in their 70s and 80s at this point to get ill based on being around me. But without that boost, antibody from an infection will wane, leaving COVID-recovered people vulnerable to reinfection and mild illness from the variants. So there are some logic to natural immunity. You have broader coverage. We just don't know how long it'll last. And to be safe, to stay safe, it's highly advisable that if you've had the infection, please go ahead and become vaccinated. Another area that has proven to be of concern is about pregnant women being vaccinated. And there's more data now showing an increased risk for birth and neonatal complications for those who've had SARS-CoV-2 and those who have not been vaccinated. Pregnant women who had symptomatic SARS-CoV-2 infection were more likely than those with asymptomatic infection to have an emergency delivery. And their infants were more often experienced adverse outcomes, a new study showed. These findings were released amid reports from the CDC that despite increasing amount of evidence demonstrating the safety and efficacy of COVID-19 vaccination during pregnancy, only 31% of pregnant women are fully vaccinated against COVID-19 compared to 56% of the total US population. So what are some of the concerns and why? And I can understand the concerns. I mean, I think we all can understand the concerns, but we're in the medical field and our goal is to have this information. So when we do have patients that come in, we can exchange good, solid information and not what we might read in the headline. So COVID-19 vaccination is recommended for all people 12 years and older, including people who are pregnant, breastfeeding, trying to get pregnant, or might become pregnant in the future. Evidence about the safety and effectiveness of these vaccinations during pregnancy has been growing, so we're getting more and more peer-reviewed published literature on this. The data suggests that benefits of receiving the vaccine highly outweigh any known potential risk of vaccine during pregnancy. So that's one area. The next area is there is no current evidence that any of the vaccines, including COVID-19 vaccines, cause fertility problems in men and women. So it's not going to cause an issue there. Pregnant and recently pregnant women are more likely to get severely ill with COVID-19, and that's not something that we want to see. So we really want to get pregnant women vaccinated. Getting a COVID-19 vaccine can protect you from severe illness. And of course, that's one of the bottom lines. And I do have the source for recommendations in pregnancy that I've recently accessed. So this is a key area that we keep on seeing. There's sort of hesitancy if you're trying to get pregnant, if you are pregnant, or if you are breastfeeding. And the goal is there is no evidence to say don't do it. There's a lot of evidence saying, please get vaccinated to protect yourself and to protect your child. What do we know about boosters? Well, we're first going to talk about who is eligible because that's the hot topic right now. And the FDA has recently authorized booster shots for a select group of people who have had their second doses of the Pfizer vaccine at least 6 months before. And this eligibility will apply to Moderna's COVID-19 once granted EUA or emergency use authorization. So the FDA has approved it as of the recording. We're waiting for the CDC and then finally for Dr. Walensky to approve. Vaccine recipients who are 65 plus, who live in long-term care facilities, should be boosted. Adults who are at high risk for severe COVID-19 because of an underlying medical condition should be boosted. Healthcare workers and others whose jobs put them at risk should be boosted. I have been boosted. It doesn't mean that I'm going to run out and put myself at risk, but as I say, I not only want to have the safest dental visit for my patients, I want my staff to be as safe as possible. And that means all of my staff. People who have weakened immune systems are eligible for a third dose of either Pfizer or Moderna 4 weeks after the second shot. So here we go. It's time for this boosting thing to start for people who are at risk. Because as you know, we've had some high profile individuals in our country who have been vaccinated, fully vaccinated, but not boosted, who have other underlying medical conditions, have ended up in the hospital, and some have passed away. A key advisory committee to the FDA voted unanimously on October 14th to recommend a third dose of Moderna coronavirus vaccine for many recipients. The same panel voted unanimously the following day to recommend booster shots of J&J's one-dose vaccine for all adult recipients at least 2 months following the first dose. So there are 15 million people in the United States who have received a J&J or Janssen vaccine. All of those people 2 months following that are 18 years and older should get boosted. And that data we talked about early about the production of antibodies being lower with J&J and the protection against hospitalization and death being lower with J&J compared to the mRNA vaccines. The CDC has listed conditions that qualify a person for a booster shot. Hypertension, I have to say that I fight that off. And heart disease, luckily don't have that. Diabetes or obesity. And obesity is one of the main factors that we're seeing in our hospital and hospitals around the country, and diabetes as well. And as part of the healthcare team, not only we talk about good oral hygiene, but nutrition issues come into play. We can help our patients who are obese. We can help our patients who are diabetic stay healthier, growing periodontal treatment, making sure they're on their medications, et cetera, et cetera. Cancer or blood disorders. And I did pull out multiple myeloma because General Colin Powell, who did pass away earlier this week, was 84 years old. He had multiple myeloma. He also had Parkinson's. He had been fully vaccinated, but he had not been boosted. And so I don't want people to fear that just because one of our most famous generals in recent history and the first African-American Secretary of State passed away, that these vaccines don't work. He had severe comorbidities and he was older. All of that doesn't take away from the fact that his history will be remembered in a positive fashion. A weakened immune system, such as some of the patients that I treat, puts you at risk. Chronic lung, kidney, or liver disease, dementia, and certain other disabilities. Pregnant women, which we just spent some time on, and current and former smokers. And so I know that we talk to our patients about smoking cessation. I know that, especially in hygiene world, having to clean up a tobacco stain is not one of the highlights of our day. So working on smoking cessation, things that we do as part of our preventive care, talking to people about taking their blood pressure medicines, helping patients stay on their diabetic medications, realizing if a patient is really obese, it puts them at more risk, and just having the conversation. If a patient has cancer or blood disorders and you're treating them, and we do that here, we definitely want to make sure that they are boosted. weakened immune systems, chronic lung disease, kidney disease, liver disease, etc., pregnant women, and former smokers. These are differences that we can make and differences we do make on a daily basis. The FDA has authorized boosters for workers whose job put them at high risk of exposure to potentially infectious people. In that group are emergency medical workers. I added healthcare workers because, again, 50% of our patients that come in, we don't know their status. Education workers, food and agriculture workers, manufacturing, corrections, postal service, public transit, and grocery store. So people who are in contact with the public. We are not only in contact with the public, we're in their mouths. And so even though we have fabulous techniques to control aerosol, rubber dam, high volume evacuation, extraoral suction, HEPA filtration, a recent study just came out proving that HEPA filtration in COVID hospital areas really does work compared to non-HEPA filtration areas. So to prevent nosocomial infections. So we really do know that we can take our steps that prevent it in the dental field, but we also want to protect ourselves. I had a recent conversation with one of my, a friend of one of my previous residents who said, she's really tired of getting her face shield covered with splatter. Well, if you use an extraoral evacuation system like we have here, your face shields will stay clean. You still wipe them off in between patients, but they stay clean. There's no more of that mess on your face shields while working on a patient or after working on a patient. The side effects of the third dose are similar to the first two, either Pfizer or Moderna's vaccine. And that's what we expect to see, and that's what we've had seen. The report used data from almost 13,000 people who received a third dose of either vaccine since the FDA authorized them for immunocompromised people in August, found no new serious or unexpected patterns of side effects emerging in people who do get the booster. I am one of those people who did get the booster, and I think I told you when I got my second shot was during the NFC Championship game. The Friday before, and I had to put together some work on that Saturday. And yes, I'm tired on Saturdays, and yes, my muscles ache on Saturdays. I still put 2 webinars together, and on Sunday was able to watch my team win a very important game to get them into the Super Bowl. So I had minimal side effects other than a sore arm. I didn't even have a sore arm after my third boost, but we'll get there in a moment. The CDC reported that about 80% of people getting a booster shot reported a local reaction, like pain in the injection site, like I mentioned, compared to 77.6% of people who reported that reaction after their second dose. After a third dose, 74% of people reported a systemic reaction, such as a headache or fatigue, compared to 76.5% of people who reported that reaction after the second dose. So again, we're seeing that the numbers are quite similar. There's not a big difference. The initial findings indicated no unexpected patterns of adverse events. And so most of these were mild or moderate. And I think that's really important to note. Can I get a flu shot at the same time as a booster? Well, I know you shouldn't use one individual's experience as living proof, but yes, I did get them both at the same time. I got the Pfizer booster in one arm, the flu shot in the other arm, and please get your flu shot. We've already seen an increase of 23% compared to last year of flu. And it appears that this year's flu shot actually did nail it. So that's actually a good thing. So you'll be more protected. The CDC, don't take my word that I survived from having both at the same time. The CDC said the COVID-19 vaccine may be administered without regard to the timing of other vaccines, and many pharmacy sites are allowing people to schedule a flu shot at the same time as a booster shot. So yes, you can get them both done, get them both over with, and enjoy the rest of your day. The FDA is to announce that people can get a coronavirus vaccine shot that are different from their initial dose, this whole mix and match booster approach. And there's a little bit of logic to that. When we first got our vaccines, we were given whatever was available. So I was given Pfizer. That was what was available. I've known the company since they developed fluconazole or diflucan all those years back. I worked with one of their CEOs when I was on a presidential advisory council for HIV. I had faith in the company, and so I had no issue. Moderna was a new company, didn't know much about them, but now we know that their vaccine is a little bit more potent. Okay. It's not that I don't think that the FDA, what they meant by this was to say, okay, when I go into whatever pharmacy, this is the vaccine that I want. I don't know that that's what they meant. I really think what they wanted to do was to at least allow some flexibility in the system. So if you go to a place and they have Moderna, go ahead if you've had Pfizer. If you go to a place that you've had Moderna and want to wait, find another place or go get Pfizer. They're both very, very, very effective. However, J&J's vaccine has been shown to be less effective than the mRNA vaccines. So there really is a lot of focus on how to boost protection for these recipients of the single shot. Should it be with J&J shot or with another vaccine, which uses a different technology? So another question that we look to answer. When we talk about a mix and match approach, let's talk about what we should boost with. For Moderna, it's really not the full vaccine if you've had Moderna. It's basically a half dose. Some are saying a full dose, and that's really what's out, and that's what was tested as a part of an NIH trial. So I'm sure that when the recommendation officially comes out, which would be on Friday, I believe, of this week, that they will probably say full dose. But that's a question that still needs to be answered and will be answered in the next day or two. The data show that while recipients of the J&J vaccine may benefit from a second dose of the original, they may derive even greater protection if the boost comes from a different vaccine technology. The study showed that a second shot using the Moderna vaccine triggered the biggest boost of virus neutralizing antibodies in J&J recipients, resulting in a 76-fold increase in the antibody levels. That is enormous. A Pfizer booster was also enormous, showing a 35-fold increase. A matching J&J booster triggered only a 4-fold increase. If I have a patient who comes in here who, for whatever life circumstances, they ended up getting the J&J vaccine, I would definitely recommend that they switch technologies. Again, getting a Moderna vaccine after someone's had that single dose of J&J, 76% increase in antibody levels. That's what protects us. The Pfizer, 35%, but just using the J&J was only 4%. Another issue that might really impact our decision about which boosters we're going to use was the very rare clotting side effect that we saw more common in women under 50 who received the J&J vaccine in the United States and the AstraZeneca vaccine outside of the United States. Again, a very minor concern, but something that was noted. If healthcare providers have the freedom to recommend any booster, they can recommend any mRNA dose as a second shot to people who may be at increased risk for an adverse event. So this was a preliminary report. This is a study that is out there and just recently published. So again, I think it's very important that we know the whys we're getting recommended to do certain things and which is the best option. And that's what I'm trying to share today. There's also something else out there that we need to take a look at. There is actually an oral antiviral new medication. Merck has submitted an emergency use authorization request for an oral, a pill antiviral, molnupiravir, as a COVID treatment. Our present antiviral treatments are either by injection or by infusion. So having a pill that could keep people out of the hospital who have mild and moderate disease would be an enormous step in the right direction. A phase 3 trial released by Merck earlier this month indicated that patients who received this medication were about 50% less likely to be hospitalized or die from COVID-19 compared with patients who received placebo. Again, this was one of those randomized controlled trials. The trial showed that the medication appeared to demonstrate consistent efficacy against SARS-CoV-2 variants. So there's been a lot of information that we shared, and this is just a demographic graph to show you the advantage over the molnupiravir group versus the placebo group. And this was by press release, and I don't normally go by press release, but it did come from Helio. So we know that there's benefit to this medication. It's an oral medication. It's not an infusion medication. It is not doing monoclonal antibodies or anything of that sort. This is just a pill that you take. So as always, if there are new topics that you'd like us to discuss, please don't hesitate to let us know. What information that we share is really truly based on what your concerns are and what areas you would like us to cover. As always, it's been my pleasure to be able to talk, and I'm going to turn it back to Gary, and thank you for the opportunity.
Thank you very much, Dr. Reznik, for that update. If you have any questions, concerns, or suggestions for future topics, please email us at webinars@henryschein.com. Also, please subscribe to our YouTube page by clicking the button below. I'm Dr. Gary Severance with Henry Schein, and as always, until next time, stay safe and stay informed.